All right, good afternoon, everybody. I'm going to introduce our next speaker, Dr. Jennifer Rael. She completed her MD in 2000 from the University of New Mexico School of Medicine, and she went on to complete her residency in pediatrics at the San Antonio Military Pediatric Consortium in 2003. She served as a general pediatrician for the U.S. Army at Fort Carson, Colorado, as well as serving as the general medical officer for a year in Iraq during Operation Iraqi Freedom 3. After being honorably discharged, Dr. Rael then returned to the University of New Mexico to complete a fellowship in neonatology in 2010. She's been a member of the UNM faculty since completing fellowship and is currently the medical director for the NICU and ICN4, and she's also the medical director for the outreach program. So I'm hoping, Jen, can you hear me? She can hear me. All right. So today she's going to be talking to you guys about CPAP management. So Jen, welcome.
Thank you, Kathy. Let me see if I can figure this out and share my screen.
It's always a fun adventure with Zoom, isn't it?
Yes, it is. All right.
There you are.
There I am. So everyone can see it?
We can. Thank you.
Perfect. All right. Hi. As Kathy said, I'm Jen. I'm one of the neonatologists at UNM, and I was asked to talk about non-invasive ventilation. So I hope y'all find this useful. And any questions that you have, I'm happy to answer. And you can always email me or call with any questions or concerns. So first, I have nothing to disclose. Let's talk about a brief history of CPAP. Sorry, I'm trying to, there we go. All right, so the first newborn specific respirators were actually, there was one designed by Alexander Graham Bell in 1889. And this showed encouraging results on small animals. And he actually shared it or presented it at the American Association for Advancement in Science, but it was met with little enthusiasm. So flash forward a little bit to the iron lung. So this was developed by Drinker in 1929, and it was actually successfully used in 1931 by Murphy et al. On asphyxiated newborn infants. And I actually, while putting together this talk, I found this article in NPR, actually from late October of this year, about decades after polio. One of the people who was affected by polio, Martha Lillard, I believe was her name, is among the last to still rely on the iron lung to breathe. So they're still in use today, although very rare. So I just thought that was pretty interesting. If you have seen pictures of the iron lung, it looks kind of prehistoric. So the iron lung is based on negative pressure ventilation. And so it applies negative pressure intermittently around the patient's body and chest wall, and this results in a pressure drop around the thorax. And this negative pressure is transmitted to the pleural space and the alveoli, and this creates a pressure gradient between the lungs and the mouth. So if you remember the photo I showed of the iron lung, their body is inside of the tube, essentially, and the head is outside, and there's a sort of a ring that causes that creates a seal around the neck to then cause this pressure gradient. And as a result of the pressure gradient, gas flows into the lungs. Fast forward 60 years later, after the poliomyelitis epidemic throughout Europe and the US, there were a number of positive pressure volume controlled ventilators that were being designed and put into use. And the tank, or the iron lung, was largely considered to be obsolete by this time. And in 1959, 2 ventilators had been used in newborns that were positive pressure, one in Sweden, the Engstrom, and the Radcliffe pump in South Africa. So then in the 1960s, we're moving from negative pressure ventilation to positive pressure ventilation. And this really, the development of positive pressure ventilation really took hold with the development of jet aviation. And after that, towards the end of the Second World War, we saw the development of small, compact, intermittent positive pressure breathing devices, such as the Bennett and Bird. And here are some pictures of those machines. The Bird here, the darker one, and the Bennett here. So these were some of the very first positive pressure ventilators. So 1970s to 80s, the mainstay of neonatal care was really intubation, invasive ventilation. And then we added antenatal corticosteroids that helped the lungs mature, and surfactant. And this significantly reduced neonatal mortality. However, with the decrease in neonatal mortality, different morbidities increased. One of those being bronchopulmonary dysplasia, or BPD. And it is because of BPD that we are looking into non-invasive ventilation, and ventilation that doesn't cause as much barotrauma, volutrauma to the lungs. So again, in the late 70s to early 80s, we have a progression to non-invasive ventilation on the adult side. And actually, Gregory et al. In 1970 presented nasal CPAP as a mode of ventilation to the Society for Pediatric Research meeting. So this is the first time that we're seeing non-invasive ventilation being used in the pediatric population. So let's talk about just really quick transitional physiology and what we need our ventilators, either invasive or non-invasive, to do. And it's truly the establishment of FRC, functional residual capacity. So what we need our ventilators to do is to establish that distending pressure so the alveoli don't collapse, which will help them to successfully adapt to their postnatal life. With preterm babies, they are at a disadvantage just because of the immature lungs, the insufficient production of surfactant, and the highly compliant chest wall, along with an immature respiratory center. So these are sort of the things we're trying to overcome with our ventilation. So there are 4 main approaches to non-invasive respiratory support. Nasal continuous positive airway pressure, and that can further be broken down. You can deliver just plain CPAP, or like BiPAP or CiPAP, which adds a slightly higher peak inspiratory pressure with a rate to your CPAP. Then there's high flow nasal cannula, which has really come into favor over the last 10-ish years. And then nasal intermittent mandatory ventilation. So this is your NIPPV, your the high frequency oscillatory ventilation, or jet ventilation via the cannula, which is currently sort of coming into favor and being used in different NICUs around the US. And then neurally adjusted vent assist, or NAVA. So one of the principles of NIV, you need heating and humidification of the inspired gas. because studies have shown that dry and cold gas can result in impaired ciliary function. It reduces clearance of secretions, and you can damage the airway mucosa. And because of this, that can impair lung function and thereby reduce compliance and your FRC, or functional residual capacity. So let's talk about the different modes, and really the modes that I think other outside of NICUs that are going to use. So, you know, on the front line with delivery of the babies, either in the DR or before transport gets there, or if they're an older baby and you're keeping them, the modes you're going to probably use most are the CPAP and high flow nasal cannula, and possibly some of the nasal intermittent positive pressure ventilation. So let's talk about CPAP first. This is a continuous flow, single level. You can do bubble flow or a bi-level biphasic flow. And here is an example of bubble CPAP. What is nice about bubble CPAP is it's a cheap alternative to a vent. So in resource limited areas, it's really nice. And then biphasic CPAP, so you can see that there's a rate, you have an eye time, and you have different pressures with that the ventilator is delivering. So nasal CPAP, what does it do? Again, it reduces upper airway resistance. It helps to establish your functional residual capacity. You get decrease in chest wall distortion. It augments spontaneous breathing efforts. You preserve endogenous surfactant, and it decreases the need for surfactant administration, as well as the duration and need for invasive mechanical ventilation. It provides a distending pressure that's delivered through the nares via either large bore nasal prongs or a little nasal mask without any significant flow restriction. And this delivered airflow is continuously regulated, and it is regulated to produce a set pressure. So the set pressure is typically anywhere from 4 to 7. In our NICU, we typically start at 5 to 6. It provides a distending pressure throughout the respiratory cycle. So there's no higher pressure or lower pressure. It's essentially, you're providing a peak inspiratory pressure and expiratory pressure, or a PEEP. It increases functional residual capacity and increases compliance and decreases resistance. This improves ventilation and perfusion in terms of the VQ mismatch that we hear about, and it results in improved oxygenation. CPAP, by maintaining lung volume, can reduce atelectasis. There is an increased risk for air leak syndromes like pneumothoraces. It can be associated with gastric distension, and we recommend in all our babies who are on anything higher than 1 liter of low flow nasal cannula that they actually are vented with an OG tube down. And there's concerns that this mode of ventilation is uncomfortable for the babies, especially the more mature baby. And then potential trauma to the nares just because of the pressure, either from the large bore cannulas or from the mask on the bridge of the nose. So there have been numerous studies, meta-analyses done, Cochrane reviews, looking at primary outcomes of BPD and death, and then other different morbidities. And really it's shown that any mode of CPAP really decreases the overall duration of invasive mechanical ventilation. It helps reduce the post-extubation failure, and at 7 days, there's really been no difference in success rates. So babies have been successfully extubated and stayed extubated with this mode of non-invasive ventilation. And again, bubble CPAP is a low-cost system that is available in resource-limited areas. So then let's move on to high flow nasal cannula. And high flow nasal cannula has really come into favor in the last decade. And it is because it's considered, one, to be a lot more comfortable for our patients. And so that is a huge benefit. And then there's less, thought to be less incidences of pneumothoraces, as well as abrasions and trauma to the nares. So a high flow nasal cannula, it's the small, thin, tapered binasal tubes, and they deliver oxygen or blended oxygen at more than 1 liter per minute in preterm infants. And again, the gas is heated and humidified, or it should be heated and humidified. It functions by O2 delivery and CO2 washout in the pharynx. The high flow nasal cannula systems are capable, though, of creating a distending pressure, or a PEEP, CPAP equivalent, which is not measured or controlled by the provider. So this is one big concern about high flow nasal cannula, is that you do not know what you are providing in terms of the pressure. So there's a possibility of an unmeasured and variable PEEP. And studies have actually shown that depending on what is happening at the time with the baby and the mechanics and physics of what's going on with the airway, you can deliver a PEEP anywhere from 2 to 10. So it's a little concerning in terms of not knowing what we're truly giving our patients, especially our smaller, more preterm infants. So again, it provides heated, humidified oxygen. It's delivered via the prongs in a controlled flow rate, and the pressure is produced by the airflow, and that pressure, again, is not monitored. You have the prongs that have a lower occurrence of nasal trauma compared to CPAP prongs, which is one of the big benefits, and what we've actually had to switch babies from CPAP to high flow just because of concerns for nasal breakdown. So it creates a lot less of this. And it's perceived by bedside nurses and parents to be more tolerable by the patient. And parents think that they're better able to interact with their child when they're on high flow nasal cannula versus the prongs or the flexi trunk CPAP. So that's a huge benefit, especially for our babies and the developmental concerns that we have for normal development in our infants. So it can improve work of breathing because it reduces upper airway resistance and improves ventilation by providing this distending pressure, and thereby improving lung recruitment. And there's more recently, so back in like 2017 and prior, Cochrane reviews and different studies had shown that there's that high flow nasal cannula was just as efficacious as CPAP when used as primary therapy, but more recent studies, more randomized controlled trials are being done, and they're actually showing that many infants do actually require CPAP, and high flow nasal cannula is having a higher failure rate than when compared to CPAP. So next, let's move on to NIPPV, or nasal intermittent positive pressure ventilation. And this is meant to, again, decrease the work of respiratory muscles. It provides adequate ventilation. You maintain lung volumes with the use of a positive end expiratory pressure, and then it preserves the normal physiologic function of and decreases airway injury and preventing respiratory tract infections. So NIPV is a time-cycled, pressure-limited mode of non-invasive ventilation. It is produced by your conventional ventilator, and it is used to generate 2 levels of pressures, typically your peak inspiratory pressure, or PIP, and your positive end expiratory pressure, or your PEEP. Some ventilators do it as a delta P and a PEEP. And then your rate. The rate is typically set with a longer I time on these non-invasive modes. Most conventional ventilators can provide NIP-V with a PIP, a PEEP, and a rate to produce adequate support. And the flow can be adjusted to provide enough pressure to compensate for leaks. And newer ventilators actually have NIV modes that actually compensate on their own for leaks, which is pretty nice. Non-invasive ventilation, so they are exposed to, with this, they're exposed to higher levels of airway pressure along with the constant PEEP through the nasal device. There's limitations in terms of the vent flow sensors, and this is one concern that when providing NIP-V, that we cannot provide it in a synchronous fashion, really, because of the limitations on the flow sensors on the ventilators. And so it's really hard to produce an accurate synchronization of the high pressure breath. And just studies, NIP-V is increasing in use throughout the US and Europe. In terms of synchrony, the limitations, like I said, the flow sensor doesn't really, isn't good at catching the leak and being able to compensate for that, especially in the neonatal population, just because the neonates have much smaller tidal volumes and a lot faster rates than the adult population. There is potential for adverse effects. So you can imagine getting a high breath pressure blown into your face, so you can have upper airway constrictor muscles activated. And so you get closing of the glottis, and because of this, you can actually increase mean airway pressure and have increased oxygen requirements, fluctuation in blood pressures, and delivering a breath against a closed glottis, and thereby more air in the stomach and esophagus. So there are a number of methods that are in use to synchronize these high flow or these high pressure breaths during NIP-V, and that's either with a nasal flow modulator, an abdominal impedance sensor band, or neurally adjusted ventilator assist, or NAVA, which is a sensor at the level of the diaphragm. And this is something that is very new and gaining popularity in terms of its use. And then there's high frequency NIPPV. So you can actually use your oscillator or jet to produce very high rate, low tidal volume breaths that do not, that essentially, because it's such a high rate and such small volumes, this eliminates the need for synchrony. There have been a number of studies that have shown NIP-V versus CPAP after extubation of preterm infants. NIP-V reduced failure, extubation failure, and reintubation need at 48 and 7 days post-extubation. NIP-V also decreased the incidence of air leaks, and there was no difference in the incidence of death or BPD. NIPPV and CPAP versus initial management of RDS. NIPPV has been shown to decrease rates of respiratory failure and need for intubation in these patients. There's no observed change in risk for death or BPD again between the two, and there is no evidence of harm reported. NIPPV versus biphasic CPAP for RDS. There was a 2-center randomized control trial, and they found no difference between the two. And then lastly, I want to talk about neurally adjusted ventilatory assist, or NAVA. And what this is you can see the little picture showing you that this is an electrode that's actually placed, it's embedded with a special catheter that's positioned in the esophagus down by the diaphragm. And what this does is it detects electrical activity, timing, magnitude of this activity in the diaphragm, so that it can then synchronize the breath that the vent's giving, and you can synchronize initiation of the breath, the size of the breath, termination of the breath with each patient breath that you're giving. So this is a really new and exciting mode of ventilation that we have. In summary, CPAP has been extensively studied, and it does remain the gold standard for non-invasive ventilatory support for preterm newborns. It is reasonable to manage very premature infants on CPAP from the delivery room. And there is reduced mortality and/or BPD compared to mechanical ventilation. And it reduces your respiratory instability and need for extra support after extubation. NIPPV augments the benefits of CPAP, and high flow may be equivalent to CPAP. The studies are still sort of debating that currently. But again, one thing I want to caution about with high flow is the pressure that you're actually creating is not measured and is not controlled by the provider. So here is a table just of suggested settings. So when you get a baby from delivery and they need CPAP, typically initial settings 5 to 6 with max settings of 8 to 10, although we really don't typically ever go that high in our newborn infants. In weaning parameters of 1 cm of water, and the lowest setting is typically 4. Honestly, we recommend once you're at 5, you can wean the baby, and we typically wean to a high flow nasal cannula, providing somewhere around, depending on what the baby looks like, 4 to 6 liters, max setting being 8. And again, we don't ever really typically go past 6-ish. Weaning parameters for high flow are 0.5 to 1. And then the lowest settings, it says 1 to 4, but really after you get about to 1.5 liters per minute, the rain out that you get from the humidity of your humidified gas is a lot more, less than 1.5. So really at 1.5, we switch to a low flow nasal cannula or do a room air trial. These are my references, and I'm happy to answer any questions.
I have one here from Adam. He says, if there is such variable delivery between PEEP for the high flow nasal cannula, sometimes much higher than the programmable CPAP on PEEP, then why is it that there seems to be a lower risk for pneumothorax?
That's a very good question. And I would say it is because that it is so variable. You're not always seeing that the PEEP of 10 or the higher PEEP that we're worried about, but that is a concern in the smaller babies, definitely, and a reason why you wouldn't want to really, you want to make sure that your prongs fit correctly and that there's no blanching and that there is a leak around the high flow nasal cannula, so that way you're not getting these variable pressures and then concern for pneumothoraces. That's a very good question.
So basically with high flow, they should go ahead and make sure that there is some sort of leak versus with CPAP where we want to make sure we have a much better
Yes.
seal. Okay. And so when you have babies that are both on high flow or CPAP, what is it specifically, what are the nurses looking for as far as for, how well are they doing? What kind of parameters should monitoring.
So the same things we look at in all our babies in terms of how they're doing. So their respiratory rate, their effort, their FiO2 need, typically our cutoff is 40% FiO2. So if they're needing more, we either need to go up on settings or change the mode of ventilation. Their work of breathing, so grunting, flaring, retracting, all that sort of stuff. And then babies with apnea really have a true benefit of the NIPPV because it does provide that rate to help.
In low resources outside hospitals with only high flow nasal cannulas, can you describe your assessment of what is an adequate flow versus too much flow?
So the way we do it in our NICU is if you look at the reading, typically the flow that we use is anywhere from, like I said, 1.5 to upwards of 6. But if all you have is high flow nasal cannula, you're going to titrate your flow level. And again, we're not titrating flow level to create a set PEEP because again, we cannot measure that PEEP. So you're going strictly based on the flow level and you want to look at their work of breathing and their oxygen requirement. So, you know, if you have a baby who's on a high flow nasal cannula of 2 and is still working harder to breathe, you might go up to 2.5 or 3 until you capture them and are able to bring down their respiratory rate and effort, their work of breathing, and their FiO2 requirement.
Are there any ongoing studies about giving surfactant non-invasively, and what are your thoughts on this?
There's a number of studies looking at delivering it either through like a feeding tube, through nebulization, and through different sort of what are they, the oral airways, and they are promising. We're not there yet, I don't think, but it would take neonatology to a whole different level in care of newborn babies if we're able to reliably deliver surfactant without having to intubate.
See if there's any more questions. All right,